Good morning, colleagues, and welcome to our session for today. I hope I am audible enough.
Yes, you are.
Yes, you're coming through clearly.
Okay, thank you so much. So welcome to our session for the day, where we are going to share about integrated service delivery models for key populations in Eswatini. Thank you so much for joining this call. May I request that we introduce ourselves so that we know the people who are participating in this meeting and the offices where they are from. So myself, I am Zandile Masangane from the Ministry of Health in Eswatini. I coordinate adolescent health. Thank you and over. You just switch on your mic and you talk, you introduce yourself.
Good morning, Chair. Good morning, colleagues. My name is Calvania Padiachi. I am from Nakosa, working with people who use drugs here in South Africa. Thanks, Chair.
Thank you, Nakosa. Next.
Good morning, colleagues. This is Nolu Babalo Kwaimani from AIDS Foundation of South Africa. I manage the sex work program and currently I'm in Durban. Thank you so much.
Thank you, Nogu. Next.
Good morning, colleagues. I am Cindy Mate. I work for the Ministry of Health and the Eswatini National AIDS Program. I'm the acting program manager. I've been coordinating key populations program and also PrEP. Thank you.
Yeah, good morning, everyone. My name is Sophia Maziripi. I'm the program specialist for AIDS Foundation South Africa for the sex work program. Thank you.
Good morning,
Thank you,
everyone. I'm Pigele Dlamini from National AIDS Council. I'm the head of programs here. Thank you.
Good morning,
you,
everyone. Good morning, everyone. My name is Mazui Mavuso. I work with the NAC in the Kingdom of Eswatini. I'm the National HIV Prevention Manager. Thank you.
Thank you, Mazui. Next.
Good morning, colleagues. My name is Brenda Harker. I'm the Sex Work Program Manager for Lifeline Northern Cape in Kimberley, South Africa.
Good morning, colleagues. My name is Katlego Rasibite. I work with Sisonke, the National Sex Workers Movement in South Africa. I'm the national organizer. Thank you.
Good morning,
Thank
colleagues.
you.
Good morning, colleagues. This is Chabu Sibeko, and I'm the Key Populations Technical Advisor at the South African National AIDS Council. We worked collaboratively with the South to South Learning Network to organize the meeting that we're having today, as our PRs within the Global Fund grant have to establish one-stop shops in South Africa. So thank you for making the time for the meeting, and thank you for having us.
Thank you. And next.
Good morning, colleagues. My name is Humphrey Ndondo. I am from Zimbabwe. I work with the National AIDS Council as a senior technical specialist. I will be presenting our lessons learned implementing DSD models on behalf of the SSLN champions.
Thank you. Next.
Good morning, everyone. My name is Caroline Kosho. I'm also with the National AIDS Council of Zimbabwe as the Key Populations Information Officer. Thank you.
Thank you. Next.
Good morning, everyone. My name is Bongan Masango. I'm also working for the Eswatini National AIDS Program, looking at HIV prevention.
Thank you. Next, colleague.
Good morning, everyone. My name is Mary Jesse from the National Population Council, Ghana.
Thank you. Next.
Good morning, everyone. My name is Thomas Offem. I work for SSLN in the Western Central Africa region based in Abuja. Thank you.
Thank you. And next.
Hello, everyone. I am Maria Mensah from the South to South Learning Network. I'm based in Nairobi, Kenya. Thank you.
Thank you. And next, we haven't exhausted the list. Only 14 people have introduced themselves.
Good morning,
Let's
colleagues.
continue.
This is Kerry. I'm from the South South Learning Network in Johannesburg.
Hello, everyone.
Good morning.
My name is Lamek Mageto. I'm the country engagement lead for South Sudan and Eswatini.
Thank you. And next.
Good morning, everyone. My name is Ricardo Bako. I'm the Key Populations Community Technical Coordinator with the National AIDS Council of Zimbabwe.
Morning, everyone. My name is Mohammed Khan. I'm the Southern Africa Regional Engagement Lead for the SSLN.
Good morning, and my name is Helga Musyoki, working with the Global Fund. I'm a Key Populations Advisor, and South Africa, Zimbabwe are my countries. Thank you.
Good morning, everyone. Lulama Lumika, based in Nairobi, part of the South to South Learning Network team.
Thank you, colleagues. I hope we have introduced ourselves. And once again, thank you so much for joining this important session where we want to learn from the service delivery models on key populations that is being implemented in our countries. Thank you so much for joining the session, and may I welcome you once again. And at this point in time, without a waste of time, may I hand over to Dr. Masango to also greet you so that we continue with our session. Thank you.
Thank you so much, Sandy, and good morning, everyone. For those who it's still morning, yes, I've introduced myself. My name is Bonganza Masang. I'm working for National AIDS Program in Eswatini. I'm looking at HIV prevention. And I think this will be one of the good presentations and lesson that we are all going to learn, and we're hoping that those countries that are presenting today, which is our country Eswatini and Zimbabwe, we are going to share almost everything that we are doing, and you guys that are here, you are going to learn more from what we are doing. And again, you are going maybe to give us maybe your comments, your thoughts on what we can do better, looking at your own experiences. So we're looking forward to everyone participating and over. Thank you so much, Sandy.
Thank you so much, Dr. Masango. And yes, colleagues, we welcome you all. Without a waste of time, we are going to go straight to our first presentation on the Mentimeter may I hand over to my colleague to continue with the presentation. Thank you.
Hello.
Sandy, sorry, before we start the presentations, we have suggested to ask the team to go to this Mentimeter and share what their expectations are for the session before we jump into the presentations.
Thank you so much, Lamek. Is that Lamek? Yeah, so colleagues, can we work on this Mentimeter? Let's go to menti.com and then use that code 2919-1834 to share what important learning would you like to get from this or to live in this session. What would you like to live in this session? To live with from the session. Please share via the Mentimeter. Go to menti.com. I'm giving you 2 minutes to do that.
And the answers are coming in, Zandi. We're happy to see that.
Yes, yes. We appreciate that. Some people want to learn from other countries about the service delivery models they are using, the best practices to follow for implementation planning, the models Zim and Eswatini used to establish the one-stop shop for key populations. What other key populations model that would be scaled up to other countries as a learning cascade? How can DSD models be scaled up to other countries as a learning cascade? Operational strategies for implementation, for implementing key pops one-stop shop. There's a lot that we are going to learn from this session. Yes. And it is always good to come with expectations when you are attending a meeting. So we really appreciate that. I think we will continue with the Mentimeter even as we continue with the meeting. Now that we have seen that other people would like to even share how their countries have tried through the processes, what's working and what's scalable, because we know that some models are scalable. Some models were tried and they were not doing well. An understanding of how other countries are implementing DSD models for key populations, yes. And we are going to learn from each other. This is a meeting that will also allow us to benchmark from each other. We really appreciate SSLN for coming up with this plan of having this meeting so that we can learn from each other, we can share life experiences. Thank you so much. Practices and implementation strategies on establishing one-stop shop. How are peer-to-peer being involved within the models, especially with young people? Yes, we know that young people are part of the key populations. Okay. Thank you so much, colleagues. I think we can now, we will continue sharing through the website, the menti.com. I hope, Lamek, you are picking what they are sharing. And also, we would like to revisit this towards the end of the meeting, just to see that we were able to meet the expectations from the people. Thank you so much. And now we are going to continue with our program for the day. Maybe you can just project the agenda. You are doing very well, Lamek. I appreciate that. And then at this point in time, we are going to have Zimbabwe. They are going to present to us about, they are going to share their lessons learned in implementing integrated key population focused HIV SRHR programs in Zimbabwe. Over to you, Zimbabwe. We appreciate that you responded positively to this call, and we appreciate that we are going to learn a lot from you. Over, take the floor, Zim.
Thank you, Madam Chair. As introduced, my name is Humphrey Ndondo, and I'll be presenting on behalf of Team Zimbabwe. Our presentation is titled Lessons Learned Implementing Integrated KP-Focused HIV SRHR programs in Zimbabwe. I would like to apologize for our leadership. They wanted to really join this meeting, but this week we also are writing our Global Fund concept note for the GC7. So they've asked that we present on their behalf instead. I'll switch off my video. I just wanted to say hi, so you at least have an indication or a sense of where this voice is coming from. And then I'll proceed with the presentation. Next slide. So this is our presentation overview. We'll go through an introduction. We'll reflect on the progress towards the UNAIDS fast-track targets. We are going to talk about person-centered integration and inclusion of key populations. We're also going to talk about some of the service delivery models for key populations that we employ. We're going to discuss some strategies for implementing some KP-DSD programming and how integration for harm reduction and DSD models, what we have done so far, and an example of KP-DSD approaches for MSM and also for sex workers, and some barriers to implementing integrated HIV service, SRA interventions. And then we will conclude. Next slide. So we want to appreciate that key populations constitute a small proportion of the general population globally, but they shoulder a disproportionate burden of HIV-related morbidity and mortality. And 70% of all new infections were from key population, that is sex workers, gay and bisexual men, and other men who have sex with men, people who use and inject drugs, prisoners, trans and gender diverse persons, in a study conducted by UNAIDS in 2021. Some of the challenges that global HIV programs for key populations grapple with include imprecision of data and gaps in evidence. In a lot of our countries, you would find that we don't have size estimates, or size estimates are dated and are imprecise or are not representative of the communities. We have size estimates that were conducted in 2 of 56 districts in our countries that we use to have a sense of the magnitude or the size of our community. So this imprecision sometimes affects our appreciation of the progress within the HIV response. Inadequate KP program scale, we find that our programs are still implemented in smaller geographies, and would want for public health impact to have a larger scale of implementation. We still experience restrictive policies and legal environments, particularly issues related to criminalization of same-sex sexual conduct, of sex work, of drug use and possession. And I'm sure the House will be, very alive to what is happening in countries in East Africa related to challenges with policing and regulating same-sex sexual conduct, and the implication this has for HIV programming overall. The pervasive experiences of stigma and discrimination driven by our austere and conservative cultures, by religion, and also by the policies and laws that I just mentioned. And also the complex and heterogeneous needs of our communities that require a lot of multi-stakeholder, layered, and sometimes expensive interventions. So these are the challenges that we see globally and regionally in terms of our efforts to respond to the HIV response amongst key populations. Next slide. We have this next slide particularly speaks to demonstrating the progress Zimbabwe has made towards achieving the 95-95-95 UNAIDS fast-track targets from 2015 to 2022. That's the first panel, and the KP-specific performance against this UNAIDS benchmark for sex workers from the Amethyst trial in 22 and the IBBS that we conducted in 2019 for men who have sex with men and also for transgender people. Summarily, I can just say that Zimbabwe is on track to achieving the goal of ending AIDS as a public health threat by 2030. If you see where I've settled there in 2022, those that know their status are at 95%, the performance of those that are on at 100%, those that are virally suppressed at 95% as well. So the country has done exceptionally well within the general population, in adults population 15 to 49 years. We also realize that we have gaps. We have gaps in our HIV programming, particularly for key populations. The national program has a suboptimal prevention access for KPs, particularly access to HIV testing and consequently knowledge of HIV status. But we also realize that once key populations are linked to treatment, our evidence shows that treatment outcomes are optimal and comparable to those in the general population, with a bit of a slighter drop in viral suppression. And I think we need to be strengthening as well our retention in treatment and ensuring that people have access to more affirming and support for ensured adherence on treatment while they are on ART. Next slide. This slide depicts our vision for a greater meaningful engagement of KPs in HIV service delivery, and particularly speaks to the notion of the need for an integrated and inclusive agenda within our KP programming. And that puts squarely the responsibility for provision of services for key populations and everyone else in the context of universal healthcare, and defines integration as the organization and management of health services so that people get the care they need when they need it in ways that are user-friendly, that achieve the desired results and provide value for money, WHO 27. So it's very important that we are coming from a journey of a total exclusion of key populations from our public sector facilities, as shown in that arrow going up. We have seen and sometimes are still implementing structures where key population programming is offered in parallel to the rest of other HIV, SRI, HRI services for the general population, that you find that there is a parallel system or something that is separate or different for key populations that is on the side. That works well. Sometimes it's got its merits. It also has its demerits. We aspire for integration where services for key populations are offered within the public sector. And I particularly single out the public sector because our strategies or our vision for a sustainable HIV response amongst key populations is that the response be entrenched in stronger public health systems and that they are led by a capacitated civil society organization. So that integration is core to sustainability of our programs. And an inclusive one is the ultimate goal. A friend of mine talks about inclusion being invited to the party and being asked to dance, because you can be at a party and not dance and not engage and be a body. So you want to be there and to dance. And to do that, we want to ensure that we understand these communities and we know the equity gaps that they face. HCD-driven approaches are important to better understand the heterogeneous needs of key populations. We need to offer differentiated service delivery tailored to meet the specific needs of communities. We need to build the capacity of healthcare workers to provide comprehensive, friendly, and affirming care. And it is not always automated that you have a healthcare worker. They understand and are going to serve in a friendly and comprehensive and competent way. We have seen that you constantly need to train and refresh on friendliness and competencies. We need to engage KP communities in the design and the implementation and monitoring and evaluation of HIV/SRI programs. The programs that we have seen flourishing are the programs that have put the centrality of communities as a core component of responding to the HIV response. And community-led monitoring to strengthen the community feedback loop on the quality of integrated HIV service delivery for KPs is important, because with integration, you at times compromise the level with which you are able to respond to a most person-centered challenges that communities come with. So it is very important that you have a feedback loop from communities that gives the pulse of your implementation some life, that it is responsive to the needs that communities come up with. Next slide. So I'll go very quickly through this one. This is the cascade of HIV, an HIV cascade, where it demonstrates our work in Zimbabwe from the time that we reach out to communities using a peer-led outreach approach. We reach out to communities, and the approach with HIV prevention services, including a referral for HIV testing as an entry point. Once they are identified, they are linked to testing, and they are enrolled either in HIV treatment if they are positive, and they are enrolled in HIV prevention if they are negative. Our program is moving to a status neutral approach. We had already done so for key and vulnerable populations, and more broadly now, we are doing so for the broader national response. And once they are initiated and on ART, and they are sustained on ART until they are virally suppressed and they cannot transmit infection to others. And when they are on PrEP, they maintain a PrEP or a prevention modality of their choice and reduce rates of transmitting and break the chains of transmission of HIV. And this all works within a context of an enabling legal and policy environment where we reduce violence and stigma and discrimination, and where we continuously monitor the program using data. And above all, we are layering onto these harm reduction approaches. This is something that is new, that we are particularly working on as a country. So the next time we will be presenting this model, it will have a tweak to it to layer on our approach on harm reduction. Next slide. So this slide speaks to the strategies for implementing integrated KP differentiated service delivery programs. And the way we do it, we recommend a hub and spoke model where a static facility operates as the hub with variable outreach points radiating from each facility. We do feel that when you're working with key populations, because of the challenges and context that we've described earlier on, it is redundant for us to be working from clinics or from hospitals with walls. We need to reach out to communities to provide DSD approaches that are beyond a service that is bordered on brick and dagga, a kind of approach that we used in the past, that when someone needs care, they will find the practitioner at a health facility. And that we have evolved over these years, and really our interventions are also reaching out to individuals that are HIV negative that may not need to come to a healthcare facility to access, for example, a prevention modality like PrEP. So it is very important that we ensure that our approach is differentiated, it is decentralized, and that it looks at a multidisciplinary team in distinct geographical clusters finding key populations at the right places with the right interventions, differentiated and disaggregated for sex workers and their clients, for MSM, for transgender persons and other key populations, that service integration, that there's task sharing and shifting, and also includes self-care, and that we layer HIV prevention care and treatment services with SRH and STI services, and that we also have peer-led demand creation and retention support through KPPS and KP Health Assistance, and that we incentivize KPPS to mobilize and navigate communities to bolster our first 95 that seems to be struggling. We demonstrate our mapping exercises to your right in the bottom right. This is Harare province and our mapping of the different players and partners providing services either as on-site clinics, as outreach points, as a drop-in center. So we also need to make sure that we do regular deep dives of changes in the typology of the work that we're doing or in the mapping of hotspots to better appreciate where the burden of disease or rates of new HIV infections are occurring. Next slide. Moving quickly through this one it shows the importance of human-centered design approaches to improve KB differentiated service delivery. And we have put there some of the questions that we think programmers need to ask themselves in contexts where it is extremely restrictive to change the policy and legal environment. There is a lot of work that we can do on the ground with communities. And we've proven this from our work using this human-centered design approach, that by shifting social forces, we need to continuously interrogate our services for barriers and facilitators for uptake by key populations. So asking how we might cultivate more supportive and open dialogue around HIV in the KP community, how we might create the conditions for KPs in their diversity to feel comfortable when connecting with HIV services, and how we might transform the social narrative and implications of living with HIV. And also when people eventually come to our services, how we might make the HIV testing experience feel private, feel more trustworthy and seamless for KPs, and how we might KPs see providers as empathetic, as knowledgeable and supportive allies for their health cause. And also how we might, how information exchanges for health services may be more discreet and less intrusive for KPs. And I'm sure as I'm reading these questions, you've had feedback from communities where they have said that I felt like I was the doctor in the room. I was literally teaching the healthcare practitioner about what I needed done for me. Next slide. So this slide shows the approach of combination HIV prevention that we follow. So this is biometrical approach, the structural approach, and the behavioral approaches. And it shows the package of services that we're currently offering in Zimbabwe. I have circled there in red the harm reduction because this is the new element that we are beginning to program for. Next slide. So with this nuanced thinking of programming, it needs to be really followed with the data again. When we have worked in the past, our data was not picking, the disaggregation for key populations. We have since ensured that our DHIS2 platform and our electronic health record system have KP data that is disaggregated, and we can be able to have HIV prevention and treatment cascades that track clients even as they move from one mechanism, a private provider, to a transfer into a public sector facility. And these forms, you'd see this Ministry of Health and Childcare monthly return form is found at a facility and has this disaggregation, and healthcare workers are capacitated on how to use and how to elicit informations and enter it into the system. We also encourage routine collection of data on structural interventions. The country every other 3 years conducts stigma index surveys and also a legal impact and environmental assessments. We are due for a human rights study, and as soon as we have secured funding, we should have that rolling in place. The other element of the work that is very important on this is community-led monitoring. I've said earlier on how it is important to get a community feedback loop into the performance of the program and ensuring that you are responsive to the specific needs. Next slide. So this is the progress that we are doing, integrating HIV prevention and SRA-HRR models for key populations, and particularly with people who use and inject drugs. We developed in 2018 training manuals for service provision on key populations, including job aids and a minimum service package for differentiated KP subgroups. We also had our legal environment and impact assessment that I spoke to in 2019. In 2020, we developed the treatment and rehabilitation guidelines for alcohol use and substance use disorders. And again, in that year, we developed a Zimbabwe National Drug Master Plan. In 2022, we have developed and reviewed we actually have reviewed the operational service delivery manual with special considerations for key populations. And we have also reviewed our national HIV prevention program with the PSAT. I think last year, a lot of the countries on this call were busy conducting their PSATs, and we've done this across all the range of key populations that we want to work with, save for prisoners. We just completed our review of our National AIDS Strategic Plan to align with other national frameworks, the Global Fund, etc. And we will be developing our KP implementation plan as soon as we are done with our GC7 concept note. Next slide. So this is an integrated sex work program model for the biggest sex work program that we run nationally, implemented through our partner on behalf of the National AIDS Council and the Ministry of Health and Childcare. We have 86 implementation sites with existence, community-based outreach and service provision, what I was saying around the hub and spoke model, and it's a comprehensive service that also has one-stop center approach. It has 12 state clinics, 34 local mobile clinic sites, 10 drop-in centers separate from public facilities, and 6 specifically offering, risk reduction and micro-planning for young women who sell sex and have a girls club. In it, we have 30 highway mobile clinic sites that are co-located in public sector facilities. And then the last 2 slides demonstrate, next slide, the last 2 slides demonstrate an example of a DSD approach that we have done following a human-centered design and gathering insights on MSM. What we want to assert and what we want to share in these specific slides is that we want to emphasize that key populations are a heterogeneous community. And when we say men who have sex with men, we are talking about a variety of men, from men who do not identify as MSM or participate in MSM activities or participate in MSM relationships secretly, and from those that actively engage with the MSM communities and those that are advocates. And these different typologies of individuals interface with healthcare services in different ways and face barriers and facilitators to accessing care in different ways. So we really do encourage that we sort of tailor our response to particularly speak to, improving HIV testing modalities and removing the barriers that could speak to the specific challenges that individuals face. And this needs to be done for sex workers, younger sex workers, older sex workers with aging challenges, etc. So that emphasizes that and the need to tailor interventions. Following this human-centered design insights on MSM, we developed an intervention called Color Z, which is on the next slide, that tailors the service delivery at a facility to particularly respond to the challenges that the key populations, particularly MSM in this instance, had identified. So they are greeted at an entrance or an entry point by a friendly greeting by the security personnel, by the staff that are manning the front desk. There is subtle signage throughout the facility to demonstrate that this is a KP-friendly facility. And staff in these facilities were learners that have an indication that this is a site where we provide KP interventions, or where staff are expected to be KP friendly or have been trained in KP friendliness. There is a waiting area that is private that plays relatable videos, and a wall where communities interact to share their comfort levels and their experiences in life. And the testing experience is made to be expressed. You can test first, approach, and we have sensitive providers and gift bags that are pre-packed so that people don't have to be asking for condoms and lubricants. Others are shy, so they say, no, provide a gift pack of consolidated prevention modalities that one would ordinarily use, and pack them already so that we pick these bags up or during the time that we come for service delivery. Last slide, I think the last two slides then speak to some of the barriers that we have spoken to: incomplete packages, insufficient data, inadequate differentiation, inadequate program scales, stigma and discrimination, criminalization. And currently in Zimbabwe, we are experiencing a huge HRH challenge, the diminishing pool of KP-friendly and clinically competent healthcare providers. One of the last slides is around the considerations for successful integration. And I think what is important here is that if we're going to integrate, make sure that we are integrating in a lens of equity. So use equity as the lens by which you are particularly integrating to respond to the specific needs of the communities that have been left behind. Make sure that you maintain the differentiation to cater for the heterogeneous needs of communities, and that this is a mechanism for sustainability. If you're not doing that to ensure that the services are then sustainable and that the government takes over the responsibility of providing care in public sector facilities, then the programs will continue in limbo. Evidence-driven, there needs to be evidence, continue to gather evidence through CLM on how on the pulse of activities and how these are particularly important. Dr. Nkengasong has said that we shall strive to know and close the equity gaps for key populations. And I will end there and thank you.
Over. Thank you so much, Zimbabwe. Thank you so much, Zimbabwe. Thank you so much, Humphrey. That was mouthful. And then again, thank you so much to everyone that is here, because I can see on the chat platform, people are asking questions. But can we go straight to Eswatini and then have questions after the Eswatini presentation? Over to you, Eswatini.
Good morning, colleagues. Thanks, Chair. I've previously introduced myself as Cindy Matt, as we can see in the screen. So I'll be taking you through the service delivery models for key populations in the country. May we move on to the next slide, please? So I will start by giving an overview of our HIV epidemic in the country. We have a size population of 1.2 million. And amongst those, we have people that are living with HIV that are estimated to over 215. In actual fact, we are at 221,000. And then when we check our HIV cascade, and based on the UNAIDS global targets, the 95, 95, 95, based on our population-based HIV impact assessment that we've just conducted in 2021, we have done so well as a country, where we've seen that we've surpassed some of the pillars, especially those that are enrolled on ART and also those that are virally suppressed, and we still have a small gap with our first 95 of case finding, as we are at 94. And when we further disaggregate the HIV cascade per sex, by sex, we have seen that we've done so well within the females. As you can see that we've been able to achieve the 95 and surpass some of the pillars within the females. Where we're having a gap, it's with the males with the first pillar, where we are at 92. And then on our HIV prevalence, I must also acknowledge that this was conducted during our SHIMS, while OFIA was conducted during the COVID-19 pandemic, the 2020 and 2021. So it also affected how we were implementing the survey. So when our HIV prevalence shows that currently we are at 24.8%, and in 2016 or 17, we were at 27%. And we've also managed to reduce our HIV incidence. We are coming from 1.36, and currently with the 2021, we are at 0.62%, which is translated to 4,000 new infections that are expected to occur within a year. Previously, in the last year, our estimation of occurrence was 7,000. So we really appreciate what the country has done in terms of reducing the incidence rate and the new infections that are expected. May we move on to the next slide, please? So our next slide will be the EPI review for our key population in the country. We are defining our key population to include the sex workers, men who have sex with men, the transgender, PWID, and then the prisoners. And then with this presentation, we have excluded the prisoners. So it's the four KP types. So in terms of our population size estimates, which we've also conducted in 2021, it was integrated in a biobehavioral surveillance survey. In 2015, we conducted the first population size estimate, and for sex workers, the female sex workers were at 12,274. For MSM, we're at 5,085. However, when we conduct the second one in 2021, we've seen a drop. It was also conducted during the period of the COVID, which also affected some of the methodologies that were used. Yes, sorry, it was my internet this side. I got cut off.
Oh, okay. You can go ahead.
Okay. So sorry, colleagues, for that. So I was still talking about the population size estimates and the challenges that we've had. So that's why we're using the range, which is now encompassing the program data beside the size estimation that was done during that integrated biobehavioral surveillance. And then for our PWIDs, we are at 854, which is based on an assessment, and our TGs were at 105. Then when it comes to the HIV prevalence based on the IPBSS, which was targeting the sex workers, female sex workers, MSM, and the TG. For sex workers, female sex workers were at 58.8% in 2021 and 21% for the MSM. And then for the TG, because we have just included them for the first time in the 2021 IPBSS, we are at 41.2%. And for the PWID, we haven't done any biobehavioral surveillance in the country. However, when we're doing our programmatic mapping and size estimation, we included some questions just to get from the PWID their zero prevalence, and is estimated at 18%. The map on the side, it shows the map of the country. And as you can see within that legend, these are the community-based organizations that are working within the KP, which includes the sex workers, the MSM, the TGs. They are implementing the KP program, but mainly it's the demand creation that they are conducting to mobilize their KP peers for the clinical services which are provided through the the mobile outreach conducted by FHI 360. So may we move on to the next slide? So in terms of the HIV treatment cascade of tracking the 95-95, for the first 95, we are at 88%. That is the combination of all the three KP type, the female sex workers, MSM, and then the TG. And for the second 95, we are at 97%, and the third one, we are at 94%. Since we've also included the recent infections, so that was part of the study, we have realized that 7% of those that were tested positive, there were recent infections within the study, which was within the first year. May I have the next slide? So in terms of the DSD models that we're implementing in country, we are providing our services through an outreach clinic, through outreach clinics, which is providing services for all the key population, which I've highlighted. That is the MSM, sex workers, PWID, and also the transgender in the hotspots and also in safe spaces. And we have drop-in centers. We have 2 in the country, which is also providing the combination of the clinical services and also provide as a safe space for engagement of the key population. It also targets all the types within those centers. And then we have the hybrid, which are our facilities, which include the public and also the private. They still access services there. So these are the 3 models that we're implementing in country in reaching the KPs. So may we have the next slide? So in terms of our KP and also the mobile outreach, which are the main ones, as I've already alluded that we have 2 KP centers which are situated in the 2 cities in the country. And it was established in 2019. It was spearheaded by the Minister of Health, which is an advantage to have the KP coordinator within the Minister of Health, which makes it easy whenever we want to implement some of the strategies for reaching our KP. These 2 community centers, they are meant by the KP organization, and we provide clinical services 3 days in a week. The other days, they are safe for the non-clinical services. We have FHI 360 that is supporting the organization that is manning these KP centers. I've already mentioned that the target is all the KP types except for the prisoners. And our clients, they can be mobilized through the peer education program. And we also have an online platform where they can also be reached and make an appointment or a booking for accessing whatever service that they may need. That online application, it also allows them to assess their risk, and they can then access a service like HIV testing, and then they can be linked to a prevention services. And then within the mobile outreach, we are covering all the 4 regions, as you've seen in that map, where we're having our organizations that are creating the demand, and FHI 360 is moving around providing the clinical services through the mobile clinic, and it's targeting all the KP type. The next slide, please. So these are the service packages that are provided in these 2 models. For DIC or our community centers, we almost provide all the clinical services that are being provided within an outreach. As you can see that we are testing, we're also doing recency testing, and then the index, we're initiating those that are negative and wants to be enrolled on PrEP. We're also doing the refills. The ART for those that are testing positive, viral load testing, it's also happening there. And we are also treating them for any other minor ailments. We are also providing a psychosocial support for those that have experienced some gender-based violence and also adherence for those that we are initiating on ART. We are providing SRH services and also TB prevention for those that are testing positive, and cervical cancer screening for all, whether negative or positive. It's not like we are targeting the positive, only as we know that because of the risk. And within the KP centers, we are also doing vaccination for the KP COVID. And as I've highlighted earlier on, that we are also providing a safe space for them, which includes a resource center where they can come. There are a lot of resource documents that they can access. There is also access to internet. We've just introduced abscess prevention, I'm sorry for the spelling, abscess prevention commodity distribution for the PWID. And we have empowerment sessions, which are conducted by the outreach workers within the center, which include group session, one-on-one session, and also if there are issues of psychosocial support, there is also a PSS officer that is also providing that service to the groups. And then within the outreach, it's almost the same services that is being provided within the KP center. So may we move on to the next? And then in terms of the 3 pillars for case finding, we are conducting home-based HIV testing. That is, it will depend on whether majority is the MSM that prefer the home base and the TGs. So we have our local nurses that are going around. It will be based on the mobilization that is done by the peer educator. If people they've preferred the home-based care or it is coming from an index case, that's when we engage our local nurses to go to those places. Then we also have the mobile outreach, which I've already highlighted that it is also providing the clinical service, which include the testing. And then the drop-in center is also doing the same. And then for ART, it's provided within the mobile outreach. It is also provided by those local nurses on the home-based care model. And the ART initiation, it's also being done within the KP center. So beyond the initiations, we also have the adherence counseling or support that is provided by our PSS and also by our outreach workers. And then we are also collecting the viral load samples from the home-based clients. And then we send that to our laboratory. The same thing within the mobile outreach, TBS specimen is also collected and sent to the lab for analysis. And then we provide virtual enhanced adherence counseling for clients with high viral load to try and address the issues and make sure that we support them, whatever issues that might be there. So may we have the next slide, please? So this is just to unpack what is meant by the different modalities that we are providing, like the mobile outreach, which is providing services in the communities where these our KP socialize or they live. And then within the home-based care or the outreach, we may have a moonlight, we may have a makeshift or a venue base where we just identify a structure and we have the mobile clinic providing the service there. So usually we use the bars, the brothels, or any safe space for the TGs and MSM. And then the home-based care, that one, it includes houses of the MSM. It's popularly used by the MSM and TG, the home-based one. And when you compare the home base and also the outreach, you find that the sex workers, they prefer the community outreach clinics versus the MSM. Very few MSM are coming to the mobile outreach when you compare them with the sex workers, and they always prefer the KP center or the home-based care model. That one, it includes any safe space that they may identify. And then there are these one-on-one appointment based, which might happen within a location again, which can be a home, a workspace, or any safe space that they may identify as the KP. And then the centers, I think we've already highlighted. At times we provide the services when there is an event that has been organized by them, by the KP themselves. May we move to the next slide? And here we've shared some results that we've seen as we're implementing these different DSD models. For PrEP initiations, we started implementing the decentralized drug distribution in November 2022 up to March 2023. And we've seen that the results will improve the uptake of PrEP when we're using this model. As you can see that we have moved from 6% to 75%. And for those that were linking to ART, you can also see that from November up to December, we have improved from 67% to 92%. And for the viral load, the same thing, we have seen an improvement when we are doing the viral load testing in the different models, rather than, because initially we've been referring them to a facility, whether public or private, depending on their preferences, and we're losing most of them. But ever since we started implementing within this model, we've seen the improvement of from 21% to 99%. Next slide, please. So these are the pros and cons for these different models. For the community center one, the one-stop shops, it allows to provide the comprehensive services under one roof. Clients have static sites where they can come for follow-ups, rather than when you are looking at a mobile outreach that is moving around and based on a schedule. There is also higher retention, as clients can always come back for refills. What we've also seen is that providers are more than the clinical services. Okay, what is being provided is more than the clinical services, as you've seen that we are also offering a safe space for them to also conduct other activities. Mobilizing it includes the online, where they can use the online platform for an appointment. That is only happening within the KP centers. We haven't tried it in our public facilities. So they can make the appointment, and then when they reach the facilities, the nurses at the KP center, they're already waiting for them, and they will fast track them within the KP center. So as coins currently not operating as full-fledged, as I've mentioned that we are open for a few days. However, we've been guided by the data, seeing which days do they prefer to come. And we look at their attendance, the numbers. They are also located in two cities. So we are working on towards expanding based on the need. And then for the mobile outreach, they are flexible. They provide services where the people are at convenient time, as maximum coverage as it covers hotspots in all the region. Services are not paid for directly by the clients when you compare it to a hybrid or to a facility. Services are provided by a diverse team. So we always have the team that can provide the different services that are needed. It addresses the inequalities in service access and treatment outcome, especially among those that are not having resources to access the services elsewhere. So as coins, some services cannot be provided if they need more privacy and advanced setup, like the VIA. At times we have that challenge. Also, social and environmental conditions may affect service delivery, like the weather. So you may find that we have planned to provide the mobile outreach, and only to find that we have other issues that are posing as challenges. And then for the hybrid one, clients can access the services to facilities that are closer to them. There is no limitation of these. And then as cons, they are closed at certain time of the day. So that one we know for us, we can work at night, we can work on weekends with the outreach and the KP center. However, when it comes to facilities, they have that operational hours that are statics. And in some facilities, there's some payment, some levy that is expected from them, which is not happening within the two sites. There is also generally they are perceived unfriendly by the KP themselves because of the issues of stigma and discrimination within the health settings. Services are generic to all clients. They are not tailored to the specific KP needs. So those are the challenges that we have identified with the hybrid. Otherwise, as a country, we are working on addressing the structural barriers as it has been presented by Zimbabwe. So may we have the next slide, please? So the impact of the DSD models, provision of STS at KP hotspot, enhance the access to HIV prevention and treatment services, as we've shown that those that are testing negative, they can access the HIV prevention services. Those that are positive, they are initiated, which increase our ART initiation and also the linkage. Establishment of the drop-in centers for the KP and provision of the CCTs and DDTs services have contributed to the increased number. I think I've already shared how we have seen the improvement from where we're struggling to where we can safely say we are doing well. Through also the DSD services, the viral load suppression is currently at 99%, which we really appreciate. There is a lot of improvement. DSD improve ART retention among the KP, increase access to integrated services, which also include the SRHS services, as we are not only providing the HIV services, we've tried to integrate other services that are also necessary for the KPs. Next slide, please. So in terms of challenges, there is highly mobile clients such as our female sex workers who usually skip their appointments due to the travel. Most of the time you find that they are outside the country. So even if we try to reach them, it's not easy to access them. So that one poses a challenge. There is also new emerging KP hotspots that are implementing that the implementing team may not be aware of. So those hotspots might be missed because we are not at times we are not periodically conducting the hotspot mapping. But currently we are conducting one to try and identify these, close the gaps where we might have new hotspots that we're not aware of. Also, we have issues of transport operators that we know they are clients of our sex workers. We are having a challenge of them not being able to pick their medication, whether they're on PrEP, on ART, because of the nature of their work. Some clients are found in hotspots intoxicated, especially where we are providing the mobile outreach. Mostly it's the sex workers where we usually provide it at night or late in the day. So we find that they're already intoxicated. So when we provide other services, they are not in their proper senses for understanding what is happening. So that also poses a challenge. Clients refer to public facilities for other services like the TB investigation or further investigation in other areas. There are also delay in accessing the services, which we're trying to close that gap with the provision of these services through these models. Next slide, please. So this is the last slide. What we've learned from these models that we're implementing, it provides targeted services to all the KP types. It improves the quality of services delivered to the KPs, community level care. It also allows the decentralized healthcare services. Services are brought closer to our beneficiaries. It also improves the client satisfaction. It uses diverse healthcare teams, as I've mentioned, that we have a diverse team that usually provide the services based on the needs of our clients. It also provides for individualized care. It promotes differentiated services as patients receive or clients receive tailored packages of services based on their needs. It also addresses the inequalities in treatment access and allows for better engagement of the KP community. And it also allows the addressing the issues of structural barriers to access of health services as we try to address the issues within the other setting. I think this is my last slide. Thank you. Oh, so the last one is on the enabling factors. I'm sorry for that. We do have a DSD guideline, which we adopted as the KP program to try and address the issues that are specifically, because we've seen that the models that are in there, they were not working for us. We tried them at the beginning, and then we ended up developing an SOP that is specific to the KP program. And we also have a KPTWG that is helping with the coordination of our KP program. And as I've said, that as a country, it's working for us to have the coordinating personnel or focal person within the Ministry of Health. It helps to standardize all the guiding documents, whether it's also IEC and also trainings. We have one standard document that is guiding all the partners that are implementing within the program. So we've seen that as enabling factors for us to be able to implement the KP program successfully in the country. Thank you so much.
Thank you so much, Eswatini. So now it's time for us to have discussions, questions, and comments or any other additions. We still have comments or questions that are coming on our chat platform. To the presenters, again, please try to look at the chat platform and try to answer some of the questions. And those that are not answered, you are going to bring them here. Do we have any questions to the two presenters? We'll see by raise of hands. Okay, we have the first one. Yolan Andrews, can you go on with your question?
Thank you so much for the opportunity, and thank you so much for the great presentations. I'm very interested in the one-stop shop methodology. And just to understand, because I might have missed it and I do apologize, but is the key population center, is that a center for all key populations, whether they identify as sex workers, people who inject MSM, and transgender? And has, when establishing that, was a acceptability survey perhaps done with the key population to determine whether they would want to be part or to join or come to a center that services more than one key population?
Okay, thank you so much. That one is noted, the issue of the one-stop centers. Do we have another one so that we take two and then we allow our presenters first to be Zimbabwe, Humphrey, and then Cindy from Eswatini. Anyone else with a question? Going once? Okay, can we allow Zimbabwe to go first in trying to answer the question? Humphrey, are you there?
Oh, yes, I'm here. My apologies. I just was struggling with the unmute button. So the question is asking if the KP center that we have is in a public sector facility, and if we had done an acceptability study. So we are offering this as part of a DSD model. So our DSD models are either a public sector model or in a public sector facility run by the government or a municipality, or a private sector model that is a dedicated New Start Center facility for key populations that has response to all the key populations that we're speaking to: sex workers, MSM, transgender, and considerations are underway for people who use and inject drugs. And also the community element, you'd find that through the drop-in centers, we also have some semblance of an integrated approach for a lighter service delivery there. But for the public sector institutions that we have, in 2019, with funding from the Key Population Investment Fund, we adopted, or we identified 10 high volume facilities in 5 districts to particularly look at implementing or piloting a model of strengthening the public sector to deliver a KP-friendly one-stop shop model. And this is layering KP service provision within a general facility that provided a service delivery, HIV, SRI, HR in totality. And all the work that we did was to introduce this model with the facility staff and also with the leadership in that district and the leadership of within Ministry of Health and Childcare. And then we would conduct capacity strengthening of the providers themselves throughout training and agreeing on some of the milestones for the journey towards KP competency or KP certification. And then over time, we had a plan that we would sort of support what we did in Zimbabwe with that Key Population Investment Fund. We also are implementing what we call a Key Populations Technical Support Committee. And that Technical Support Committee has a provincial Key Population Officer who gives technical support at these facilities by coaching, by mentoring and giving technical assistance to the facility staff to ensure that we have decentralized the tools that we required to implement the KP program, the disaggregated MOHCC intake forms when they meet clients, and also support and supervision for the day-to-day work when they meet clients, and also challenges that they may face around the program more broadly. The technical working groups that you spoke about, staff at health facilities are part of those at district level. Each facility that was identified, we developed a health center monitoring committee that is implemented, that is being led by KP communities themselves. And where this where a structure for community-led monitoring already existed, we started a process of negotiating to have KP involvement or engagement within that structure to ensure that specific needs raised by KP communities are particularly spoken to. So these are active, and we get feedback on a monthly basis as part of a broader CLM structure, and also particularly as related to these illustrative sites. We have experienced that the integration works. We just conducted a facility friendliness assessment review in the beginning of the last quarter, and the results are showing that these public sector facilities are comparable in service provisions to a private sector model where it is placed, and particularly serving key populations solely, or dedicated to serve key populations solely. So we're very confident that we are taking these lessons and we'll be applying them at scale with a greater footprint and the larger in other geographies.
Okay, that's a mouthful. Thank you so much again, Humphrey. Eswatini, Cindy.
Okay, for us, the 2 KP centers that we have, they are servicing or providing services to the 4 KP type. That is the MSM, FSW, the PWID, and also the transgender. For us to establish these 2 centers, it was based on a discussion or engagement with the KP themselves. As I've already highlighted, that we do have a TWG platform where we discuss the KP program, and we also have a core team, which is, it includes the representation of all the KP type. That's where we discuss the issues. That's where the issue of establishment was discussed, and we have agreed that for us, since this is the first time we are establishing these KP centers, we rather start small within these 2 cities, because that's where majority of our KP exists compared to the other regions. So these 2 KP centers, as much as they're in 2 cities, they are also in 2 regions. So we ended up starting with the 2 so that we can learn and then later on scale up. And it also speaks to the 3 days that I've highlighted earlier on, that for clinical services, we are providing only for 3 days, and the other 2 or 3 days are there for they act as a safe space where they can do other engagements. So that also came from them, seeing that majority of the people that are coming for clinical services, they pick the days, because at first we had to do some kind of survey so that we can establish when are we seeing more numbers that are coming for clinical services, and when they engage both at community and at the center, people they prefer to come for those services that are referred for on which days. Then we come up with the 3 days. So it's work in progress. We are monitoring. When we see that people, they now prefer the other days, we may find ourselves providing the clinical service throughout maybe the 5 days per week, and see how we still open this center for the other non-clinical services. I've also mentioned that we have FHI 360 as our clinical partner that is fully supporting the center. The center is not linked to any public facility. It is a standalone site and specifically providing the services to the KP, because clients that are accessing the site are being referred by the KPPS. So most of the time, the people that go there to access the services are from the KP community. And we have a core team, which is also a representative from all the KP types that work closely with the organization that is responsible for manning the KP center. So that's how we work. And the reporting, we also have a standing core team meeting that is being coordinated by the Ministry of Health, where we're working with all the partners, both the donor level and the implementing partner, and then the CBOs, where we discuss issues. We also have the KPCLM that is also providing us with feedback in terms of how we are performing, the performance of the KP centers. So that's what I can say, that it is a standalone public facility that is specifically for KP, as it was informed by the KP themselves that this is what will work for them. Thank you.
Okay, thank you so much, Eswatini. Any other question? While still waiting for question, we can maybe jump in on the chat's questions there. One of the questions was asked by Mazwi to say on Humphrey's presentation, he wanted to know if you have defined specific program for clients of sex workers in your decentralized approach, and how is the approach to reach out to them. And then again, Humphrey, before you answer that one, another question was, do you perhaps have any other any under 18 who sell sex, and what interventions are you currently providing for this age group, if you do, in the KP centers? That one was from Nolubaba Lokwaiman. Oh, okay, yeah, that one. And then for Eswatini, the questions was okay for both presenters. This one was on the one-stop shop. I think this one is already been addressed. And then again, thank you, Zimbabwe. You are trying to answer some of the question. And then for Eswatini, they asked if it's the, what are they asking here? Okay. What else? Okay. Yolanda again is interested in learning about your tools to monitor the impact of KP centers within the public facilities and drop-in centers. on KP services, KP service delivery. Is this the data from public health sector disaggregated to reflect different KPs? So I think this one is for both presenters. Can you go over, Humphrey, to try and address the two first questions?
Thanks, Bongani. I think the Primrose had made effort to respond to the questions on the chat. I'm trying to sort of get to that. One was on young women who sell sex, and she had particularly spoken to that young women who sell sex within the DREAMS programming, supported within the DREAMS programming, and the service package includes a primary care package with HIV prevention curriculum, sexual violence prevention, gender norms, social asset building, and economic promotion and provision. They then receive a secondary package of financial literacy and education subsidies. The package is led by 16 to 24 HPS within linkage to services, and also dedicated drop-in centers known as girls clubs serve as a safe space and locations for continued support. And the other question that you was asked was related to programming for, is it clients?
Yes, of the female sex
for clients of sex workers. She also said the program for sex work also serves the clients of sex workers within the KP facilities where the sex workers themselves are served, and they're currently piloting an enhanced package of services for male sex partners of sex workers with referral through male mobilizers and at high-risk venues, and also utilizing empowered sex workers who engage with their clients and empowered to have conversations around linking high-risk men or men who purchase sex to HIV prevention and treatment services. So that's what the program has been doing so far. I think there was a question from Helga around, I think what we think, or our idea or our definition of one-stop shop for KPs. I think for me, a one-stop shop for KPs is a model in which we are ensuring differentiated service delivery in ways that are convenient and that speak to the various and heterogeneous needs of KP communities. If as a gay man, for example, wanted to go for an HIV test, at the same time, also am worried about my high blood pressure, a one-stop shop should be able to support my access to testing for HIV. If I do tend to be HIV positive, I could be asked, depending on my clinical outcomes, to perhaps screen also for TB and other STIs, and also get support in checking or initiating me on anti-hypertensive medication or counseling, therapy, lifestyle change, etc. That our programs don't just speak to linking you to taking medication for ART or prevention for PrEP. And we have been critiqued in most cases where we are doing so to be seeking out to put people on HIV treatment, other than responding to the broader need of the person. So a one-stop shop would ensure that services are integrated and people are not all over the show shopping for HIV remedies and leaving to go and shop to manage their diabetes with another practitioner somewhere else. That the practitioner of choice can be at a facility where a person or an individual that identifies as a KP can be supported in holistically responding to their healthcare needs, other than the HIV program support of.
Okay. Thank you so much. I think Eswatini, can you try and say something on the issue of the tools that we use for monitoring the impact of KP centers within the public facilities and the drop centers, and then maybe try to go deeper on are those tools, or is the data from the public health sector disaggregated to reflect the different KPs? Marcin.
Okay, thanks, Chair. For us, in terms of the tools, for both the center and also the community mobile outreach, including public facilities, we are using the same tools. That is tools that are developed by Ministry of Health. So whether it's a KP, for all the HIV services, we are using the same tool that we are using for the general population. So we have a CMIS, which is a client management information system that is within our facilities, which is using an ID for enrollment of client. It is in our private and public facilities. We are using the same for the KP. We've included a module for the KP where our service providers they can pick a KP type when they access a service. However, what we have done, that is only working for our partners that are implementing within the KP program. So it has been protected. It only allowed the access of the user to be within the KP, so that we protect the KPs from the public facilities or private. What is happening when we need the data that is in the public facilities where they might have gone to access the services, we only access the data when we use the database at national level within the health management information system. We are able to give them the database from the KP programming to also try and navigate clients that might have accessed other services, so that we may know as a KP program what other services that have been accessed by the client for which are appearing in the database. So that's what we have so far. Otherwise, it is still a challenge for us to open it up at public facilities in fear of other people accessing this information, because we know it's very sensitive. However, it's work in progress to see how we can have the facilities, the public facilities, to be able to enroll them, but not able when they want to look at the client. Maybe we protect the part of the subtype at facility level, but they can be only access the number of KPs that they've access or provided service to, so that they also know if they are reaching them. So it's still a challenge how we can protect them at public facility. However, from the KP component, we are able, using the database, but the facilities, what they've highlighted, they also want to see how many of these KP type they are providing services to. So it's what we are working on within the CMIS system. And I think we are able to get the picture from there. However, as I've mentioned, if the KP is not appearing in the database from the KP program, then it means that we are not able to track that KP within the public facility. So that is the challenge that we currently have. Otherwise, we do have the data using what I've just shared, that we are able, and all tools that we're using are the ones that have been developed by MOH, and they've been integrated in the CMI system, where we have facilities that are already on CMIS. We still have some few facilities that are paper-based. They are also using the same tools that we have printed. So that's what I can say on the use of tools and access to data.
Okay, thank you so much again, Eswatini. Anything to add, anything different from that, Humphrey, Zimbabwe?
No, Bongani, thanks. Not from my end, unless if colleagues from the team can chime in.
Okay.
Otherwise, over.
Okay. And then there was one question again. I think Humphrey, you've tried, or your team has tried to answer that one. It was from Nolubabalo again. It was asking on any work around hormonal therapy for the teachers. Eswatini, do you have anything to say about that?
Oh, thank you. I don't know how I forgot, because I saw the question. I thought I was going to include it in my response of the tools. For us, we are not actually providing the hormonal therapy as an intervention. However, what we have done, since we still have to work on our policies, however, it is a gap that we've already identified. And we do acknowledge that it is also needed, especially because we've seen that if you are providing it, it also improves the uptake of the HIV services within this group. So what we have done, we have requested capacity building from South Africa to the team, and also to our KPs and some healthcare workers, where they usually go to access supportive services, because most of our teachers, they go to South Africa to access the service and they come this side. So we wanted to sensitize the KP implementers, and also some facilities where they usually frequent, how they can manage clients who have access and they are on the hormonal therapy. So that's what we are doing at the moment. We've done the training, and we have some focal persons where they can go. It's easier for them. They are a small group in the country, as I've highlighted in my presentation, that we have about 105 that we've identified. And we also have some peer educators or peer outreach workers within the community. So it is easy for them to mobilize their peers once they've access, and then refer them to these identified facilities who have been trained to manage in case there is a client that is already using the hormonal therapy. That's what we have done. Otherwise, as a country, we are working on making sure that we enable our environment by addressing the issues of the policy. We are engaging our leadership because there are cost implications as we have to consider the implementation. So there is that advocacy that is ongoing currently. Thank you.
Okay, thank you so much, Eswatini. Any other question, last question? Any other last question before we go to South Africa and Ghana? Just for you guys to share your takeaways from this session. We're supposed to have Tanzania. Unfortunately, it looks like Tanzania is not here, but we have Ghana and South Africa. So any other question before we go to South Africa? Going once. Okay, in the absence of questions, can we go maybe to South Africa, just for you guys to tell us your key takeaways. If we have time at the end, maybe any other person who is not from South Africa or Ghana can even give us what you've taken away from these nice presentations and learning experience. Nolubabalo, you have your hand up.
Thank you so much, Chair. I think this was a really great platform for us to engage as South Africa. I really appreciate the presentation and the work that has been done from both countries, Zimbabwe and Eswatini. I think we, as South Africa, from the Global Fund, a grant, we really at the point where we really want to establish the one-stop shop model in our countries. And I liked to see the integrated approaches that both countries have utilized, specifically speaking to the component where behavioral and biomedical as well as the structural services are integrated. also the clarity around being able to implement this from both the public centers and also in a communal spectrum, and seeing the cons and the disadvantages of all these different models does really help for us, especially that we are venturing in more an integrated approach within the public centers, because that's what specifically for us, our KPs are needing. I'm also just noting some similarities as well around policy issues around hormonal therapy between Eswatini as well as South Africa. But also I was just excited to hear more about, the interventions around, the young people or the minors who sell sex and package. I'm really taking away the integration of the girls club for our one-stop shop. I think that will be incredible, because I know that we do have programs within Global Fund that speaks to our adolescents, young population, but I've always wanted to know how we can expand on that primary care package for our young key population, especially looking at the fact that in South Africa, we don't consider any under 18s as sex workers, and even have any a full package, certified by Department of Social Development, because they are considered as being exploited. But we've noticed that in terms of data, we've got a lot of these minors who sell sex, and then we really wanted to ensure that we integrate them into our program, but ensuring that we still compliant. So I think from us really as South Africa, we've learned a lot in terms of your models, and we've seen similarities, because as well as we do a lot of outreach interventions or models, we do a lot of safe spaces as well, but it's also just great to see, countries that have already started with the KP centers, both communal as well as public centers, and then learn from them. And I hope that at some point we can have an opportunity of a walkthrough, either in Eswatini and Zimbabwe, because, the everyday operational aspect of these KP centers may be useful for us in terms of like the actual tools that are utilized by the staff members that are actually running these operational centers. I've noted that, some, they are actually being implemented maybe 3 days a week and overnight. Just understanding that operational aspect could really play a critical role for us as ASA. Thank you so much, Jay.
Okay, thank you so much, South Africa. Ghana, Ezin. As in your hand is noted.
Hello. Hello.
Hi.
Yeah,
Hi.
I'm also from Ghana.
Okay, you can go ahead.
And my name is Mary. I'm from the National Population Council, and ours is to do advocacy on HIV/AIDS. I'm so glad to be learning from all the workshops. I'm just scared about the hotspots bringing up, and then because you may not know, and there are so many innocent guys around which are being affected every day. Another point is that from all the workshops that I've been listening, I keep hearing about for cervical cancers being screened freely and all. I think it's a high time that we advocate for maybe colonoscopy, because that will benefit both male and females. So maybe we should start doing that, because it's also another dangerous area that may affect the KPs. Thank you very much for your insightful presentations.
Thank you so much, Mary. Ezin.
Okay, good morning, everyone. My name is Ezinne Okeuchendo. I work for the National Agency for the Control of AIDS in Nigeria. thank you for the wonderful presentations. It was quite enlightening getting to know about the different models, integrated approach that is being used in your programming. I was also happy to learn about the young key populations that, hello, can you hear me?
Yes, yes, go ahead.
Okay, I was also happy to learn about the young key population community members you're programming for. For us in Nigeria, we are also programming for this group of persons, but because of the age of consent issues, issues around providing condoms for them and also providing other services that are not allowed about the age of consent. So I would like to still learn from the teams on how you're able to work around this. For us in Nigeria, we have one-stop shops. We have drop-in centers that we are using for key population programs. We also have KP-friendly public facilities that these key population community members can actually walk into and access service. Some other CBOs that are KP friendly, that are KP led, rather KP led CBOs are also providing interventions for these key population community members. But there is still a gap in healthcare workers' attitude, and we are looking at training more healthcare workers to be able to provide services for these key population community members. Because of funds, we may not be able to provide all physical trainings. We are also looking at online trainings in form of webinars that we can use to ensure that these healthcare workers understand about KP programming and what is expected of them. We also have our KP technical working group. We meet twice every quarter, and we then report at the National Prevention Technical Working Group meeting, where we have technical working groups from all the other five global prevention pillars that are also part of the prevention technical working group. We provide harm reduction interventions for key population community members, but we are just about starting our medication assisted therapy. Then we piloted for NSP, the needle syringe program in 3 states, and we're now scaling up. The other new intervention we have for our key population community members is the provision of naloxone for overdose management. We have just started that newly. So it's quite enlightening being on this webinar and getting to know what other countries are also doing. One other area I would like them to provide more clarification for me is how they are able to manage the non-health sector tools, how they are able to capture their M&E tools for the non-health sector, especially for the key population community members. Thank you, and over.
Thank you so much. Thank you so much. That one from Nigeria, Ezine. Yolan.
Thank you so much, Chair. I was quite encouraged by my previous colleague talking about, sorry, people who inject drugs. So I found this webinar or workshop incredibly interesting, and I think that there's opportunities for us to engage further, particularly around male sex workers and female women who inject drugs in South Africa, and I'm sure in other areas as well. They remain very hidden and unserviced. So I think developing strategies and sharing strategies between us countries would be very helpful in terms of how to identify particular areas and demand creation for male sex workers and female who inject drugs to access our services more. I think also having heard our colleague from Nigeria talk about the needle and syringe program, we know in South Africa as well, and I'm sure it's also been experienced in our speakers' countries, is that we have still, a lot of resource mobilization that needs to be increased amongst our public sector regarding needle and syringe programs, viral hepatitis services, and also opiate substitution therapy. A lot of this is still very much donor funded and implemented by non-profit organizations, where we're really hoping that our key population centers, because we have also started launching key population centers of excellence in South Africa, we're also hoping that these will also be one-stop shops to address issues such as needle and syringes, harm reduction, and opiate substitution therapy that we see not only in people who inject drugs, but also sex workers, who inject drugs. I also want to highlight that it would be very interesting for us to further engage around how do we strengthen our psychosocial support. Most organizations like our speakers, employ social workers and psychosocial counselors, but the numbers, is very limited compared to the demand amongst our people who need these services, particularly, populations who engage in alcohol abuse. We've seen, particularly among sex workers, a high number of alcohol use amongst them that is harmful. And also, how do we focus on particular strategies and programs to address alcohol use and abuse by key populations. I think the last 2 points, if you don't mind, Chair, is just to say that I've learned a lot from the speakers and would be quite interested to engage further around programs for children of key populations. I think, particularly their experiences and how they've engaged their departments of social development around programs for children of key populations. And then lastly, perhaps we could have follow-ups in informal settings, as well as my colleague Nolo has mentioned, possibly, a site visit to these countries so that we can engage more on these topics that we did not necessarily have an opportunity to engage fully in this 2 hours, but also to share tools and best practices. Thank you very much, Chair, and thank you again to the speakers for providing this opportunity for us to learn and to engage.
Thank you so much, Yolan. Thank you so much, everyone. Unless there's one burning question, but because of time, maybe it is a pleasure. It's been a pleasure for me and the team, the organizing team. And thank you so much again we have a link where there are polls where you need to answer those questions. And then maybe again, we need to thank the 2 countries, Zimbabwe and Eswatini, for taking your time to prepare the presentations and then give us all this information that you've given to us. And thank you so much to the other countries that joined again. And we've learned so much again, as much as we are the ones that were preparing the presentation, but we've also learned from the other countries that were taking part. For me and the organizing team, thank you so much for your time. Can you enjoy the rest of your days, or rather your day? Thank you so much.